Okay, so it's my honor to be here and speak after these wonderful lectures today. And so we're going to focus on pelvic pain in a female, reproductive age mostly, and if they have a negative pregnancy test. I have nothing to disclose. And so there are a lot of things which can cause pelvic pain. However, I'd like to take this time, or this limited time rather, to really discuss hemorrhagic cyst and ovarian torsion, and then touch upon a little bit on the pelvic inflammatory disease, because these three can mimic each other. And of course, there are other causes which can cause pelvic pain, GI or GU etiology. However, we don't really have time to discuss those today. So what are the main diagnostic dilemmas is the process adnexal, or is it GI or GU etiology, or is it the hemorrhagic cyst versus torsion, or less commonly, is it a tubovarian abscess? And why is it very important is that the management would be completely different. Hemorrhagic cyst would be managed expectantly with a pain control. However, with the ovarian or possible ovarian torsion or partial torsion would always, at least most of the time, nearly 99% of the time, managed surgically. So of course, what are the tests? We all know that ultrasound is the best modality to evaluate female pelvis, and it's the primary modality. But CT and MR can be used for problem solving. But we have to remember that this day and age, most of the time in the middle of the night, many institutions, patient will get the CT as a first modality, even though there's perhaps a possible concern that this might be an adnexal process. So we're going to start out with the ruptured hemorrhagic or unruptured hemorrhagic cyst. Usually they have a very characteristic appearance and also very characteristic history. It's also most common cause of acute pelvic pain in a premenopausal, non-pregnant female presenting to the emergency room. And kind of makes sense because women ovulate, and that's common, and common is to get ovulatory follicles, corpus luteums, hemorrhage into this. It's a very physiologic process. Clinical history is important because it's usually described with a sudden onset of excruciating pain. And some people say it could be related to exercise, maybe, or physical activity. Sometimes that's more common with ovarian torsion. But really, if you at least when I talk to my GYN colleagues, they say you can't really separate or discern between those two just based on this. Was it in the middle of the night, or was it during the activity? But anyways, it can really happen anytime. Obviously, anytime you have those symptoms and also clinical findings, you have to make sure that there's a negative or confirmed negative pregnancy test. And then also exclude other etiologies, such as ovarian torsion or pelvic inflammatory disease. Patients who might have some coagulation issues might be at higher risk of bleeding more, but essentially any normal patient can really have a lot of hemorrhage from a hemorrhagic cyst. And obviously, most of those patients, or almost all of them, they have to be premenopausal, because in order to have a hemorrhagic cyst, you have to ovulate. And then treatment for most of those is pain control if they are hemodynamically stable, and sometimes if they're greater than 5 centimeters, they are at higher risk of torsion. They could be monitored, and it's very, very rare that they actually will be taken to the emergency to the operating room. And most of the time, these are cases when they're truly hemodynamically unstable. So here's a case: 25-year-old female woke up with acute left lower quadrant pain, with nausea and vomiting, negative pregnancy test. What is the most likely diagnosis? There's a lot of material in the pelvis. Uterus is displaced anteriorly with this complex material, ovaries nearly next to each other, almost kissing. There's a lot of dense material. Also notice there's a lot of free fluid. There's fluid even in the Morrison's pouch. But one of the ovaries is really, you could see there's also hemorrhagic cyst within it. So in this case, with a proper clinical history, this is almost certainly just a simple hemorrhagic event from a physiologic hemorrhagic cyst. Now, the residents might say, well, pus and blood is supposed to look the same in the pelvis or really anywhere. How do I know this is not an infectious process? Now, it's almost unlikely to have this much material within the pelvis and patient doesn't have any kind of symptoms of really severe febrile illness. So there's a lot of talk about it, and was mentioned in many other talks, the consensus conference in 2009, which came up with the criteria for the benign anechoic unilocular cyst for adnexal imaging, but at the same time also hemorrhagic cysts were discussed and recommendations were made. And it was very important to actually recognize that when you're talking about some recommendations or criteria, we need to have all same criteria that we actually know that we're dealing with the same process. So usually hemorrhagic cyst is a complex cystic mass with a reticular pattern of internal echoes, and these are due to the fibrinous bands. Sometimes they're described as lace or fishnet in appearance. Now, however, if you have hyperacute hemorrhage, or you image the patient when they have hyperacute hemorrhage, then actually these masses can look more, it can look more dense, and there shouldn't be any flow within it, but you can see a stretched wall, normal ovarian parenchyma, and flow within that wall. And then, of course, pitfalls could be ovarian torsion or tubo-ovarian abscess, or sometimes even neoplasm. Now, during that consensus conference, and this probably everybody is familiar with, is the sizes. When should one possibly consider follow-up? If the cyst is greater than 5 centimeters, one may consider follow-up in 6 to 12 weeks to ensure a resolution. I think it's really sort of imager dependent or the clinical team dependent what one should do. If it's really classic, I don't think you always have to follow it up. Now, what is very important, though, if you see something in a postmenopausal patient, and because you can see hemorrhagic cyst in a perimenopausal patients, because they can occasionally ovulate, and those you should definitely follow up short term, such as 6 to 12 weeks, to make sure that this is not a mass or something that would mimic something else. So here is an example of a 36-year-old who woke up from sleep with, see the cine is not playing, excruciating left pelvic pain. And in this case, you could see there is a endometrioma and a normal pairing ovary otherwise, and also a hemorrhagic cyst. Not a lot of free fluid, but clearly her pains is due to the hemorrhagic cyst. So other kind of dilemmas with hemorrhagic cyst, as we talked about, is it a solid mass or is it truly hemorrhagic cyst? If you're uncomfortable, you could follow up this. You don't have to wait for 4 to 8 weeks. You could really do a follow-up in 3 days, 10 days, and you see change within it. You're reassured that this is a benign process. But the most confusing things tends to happen when you don't know whether it's a hemorrhagic cyst versus torsion. So here's an example when we saw this solid appearing ovarian mass. There's no flow within it, but there was this beautiful ring-like flow within the periphery. 3 days later, you could see that there is retraction within that clot. And you know, this is blood, this is a benign process. Sometimes the blood clots can look a little bit more funky than in this case. They can have angulated margins, but again, no flow internally. In the next case here, there was sort of both this hyperacute and a little bit older blood noted within this hemorrhagic cyst. And if you're not familiar with this appearance, unfortunately, this was misinterpreted as a dermoid, as the more echoic part being sort of the possibly fatty component, and these fibrinous bands representing this dot dash. And then it was thought, well, it's so big and there's acute pain, perhaps this represents torsion, and it was misinterpreted as an ovarian torsion, but which it does happen. It happens to the best of us, and it tends to basically, you know, every once in a while, like maybe once in 6 months, or even sometimes more often, I get a call from my GYN colleagues, and I say, well, you guys sent us again into the operating room for hemorrhagic cyst. Now, I don't ever get a call when we get it right, so, but of course, that would be way too many calls, so. I did want to mention, I know this is an ultrasound meeting, but I do body imaging, and it is very, very important to know that, you know, us as body imagers actually, we are not always completely familiar with the blood product's appearance on an MRI. And MRI can be helpful to sort out which entity what we're dealing with, but you have to remember that those of you who do neuroradiology or read brain MRI know that they're, you know, blood products can have a very different signal characteristic depending on their age. And the same thing happens in the pelvis. So if we're used to characteristically seeing lesions which are super light bulb bright on T1, hyperacute blood does not demonstrate these characteristics. And you need to remember in order to interpret those studies correctly. Now, when or why would you use MRI to do this? For instance, in young pediatric patients, when, like in this case, you have a 16-year-old with incidental left adnexal mass on the ultrasound, and we could not perform an EV ultrasound because they're virginal and you don't want to violate the patient, and so it was, it's highly concerning. You don't want to miss ovarian torsion, even though it has like this typical ring-like appearance around it, and that's the stretched parenchyma and internal echogenicity, kind of like hyperacute blood. But, sure, it's very important to make the right diagnosis. So in this case, we did move to MRI. And on the T1 pre, you could see nicely demonstrate that the cyst is not light bulb bright as you would expect with a little bit with acute blood, but not with hyperacute blood. But you can see a little bit of bright signal within the cul-de-sac. So there's blood in the cul-de-sac. And on the T2, it has a characteristic, very heterogeneous, complex kind of appearance. And all of these findings together are very reassuring that we're dealing with a hemorrhagic cyst. Here's another example, 13-year-old with incidental right adnexal mass. Could it be possible be a torsion? I mean, you see there's a pattern on ultrasound. It always looks the same, but perhaps for a person who's less experienced reader, and a lot is at stake, this is a very young patient, you don't want to make a mistake. Again, it's quite easy to confirm hyperacute blood on the MR imaging. Here is a pitfall case. We had a 36-year-old female with acute right lower quadrant pain with a history of prior pelvic surgeries. What is the most likely diagnosis when you're looking at those ultrasound findings? Does it look familiar to some of those lesions that I've showed you? You see flow in the periphery, that's the stretched ovarian parenchyma, internal low-level echoes kind of, but it is an acute process. Endometrioma could perhaps be in the differential, but we're trying to figure out whether it's hemorrhagic cyst versus torsion. And in this case, again, it was maybe perhaps not the most experienced ultrasound reader, and they said, well, it's easy to get an MRI, and then I can tell you if it's torsion or not. So we got the MRI, and then unfortunately, they misinterpreted the MRI, and they said, well, it's not bright on T1, so it's not blood. And also, they looked at the perfusion images, and you could see when it's running that there is flow, but it's in the periphery. And that's exactly what you expect to see in a hemorrhagic cyst. But in this case, it was misinterpreted as a torsion, which it was not. And other subtle things where you could see really beautifully on this MR, you see the one dominant follicle, which has hemorrhaged. It kind of has like these little follicles in the periphery because it pushes the others, as well as you could see that's the hemorrhagic cyst, and then that stretched ovarian parenchyma. So these are kind of the key findings. You're looking at both MR and ultrasound. And here's just a little bit easier example when you could see. So here's the hemorrhagic cyst and a beautiful claw sign from the ovary dealing with the hemorrhagic cyst. Okay, moving on to ovarian torsion. It's not as common as hemorrhagic cyst, of course, but it's very crucial to identify which entity you're dealing with, and it's about 2.7% of gynecologic operative emergencies. It's most common in reproductive age, and about 20% actually occurs during pregnancy, but when it does occur during pregnancy, it's actually during the first or second trimester because you have increased ligamentous laxity, and by third trimester, things are so tight that it will be very difficult to torse anything or move things around. Right side is felt to be a little bit more common, but obviously can happen any side, and it's really twisting around its ligaments, kind of like we saw in that, heard this morning about the testicular torsion. And then can be a lead point, and the lead point can be corpus luteum, could be physiologic cyst, or is quite often is actually a dermoid. However, very young children or young adults, as well as young women, because of their very actively ovulating ovaries, and so and they also have more ligamentous laxity, they don't really have to have a mass to have the ovary to torse. However, ovarian torsion can actually present at any time of female life, from childhood to postmenopausal period. And in the postmenopausal patients, we're more commonly looking for a mass, and the most common mass is actually a physiologic cyst. So what are the clinical symptoms? Notice how similar they can be to the hemorrhagic cyst: acute severe unilateral pain, anorexia, nausea, vomiting, palpable mass, even leukocytosis and fever. Sometimes it can be intermittent, and intermittent pain may precede acute symptoms, And of course, again, this is a great mimicker of other pelvic processes. So what happens? The ovary twists. And then you initially have compromise to the venous and lymphatic flow because the walls of the veins and lymphatics are much weaker than that are arteries. And eventually, the more the ovary swells, eventually you can completely cut off the arterial flow, and then you can infarct or hemorrhage into the ovary. So what are the imaging findings? So we are looking for asymmetry. Asymmetry, one of the ovary has to be enlarged. And it's a very characteristic enlargement. You have the stroma gets very engorged, edematous, and pushes the follicles to the periphery. And sometimes the follicles can have a little bit of echogenic ring sign around them. Also, the ovary can be displaced anterior, posterior to the uterus. Sometimes the uterus is deviated to the side of the torsion. There's often free fluid. And one of the very useful signs, which in the past we didn't really feel like we could see that well on the ultrasound, but I have to say that about 80 to 90% of times nowadays we see the twisted vascular pedicle sign. And on the ultrasound, it used to be in the older literature described that it was better seen on cross-sectional imaging, but I have to say perhaps it's one of those things that one of my great mentors said, that you only diagnose what you know or what you're looking for. So if you're looking for, and we've had a lot of teaching sessions with the residents and the sonographers, and they're really proud when they come and said, hey, I just found the vascular pedicle sign. And it can really look like an edematous tube with a twist and even a mass next to the ovary. And Doppler, and then of course, the Doppler, there's a lot of controversy about the Doppler imaging, but so, if it helps you if it's not there, but if you have flow, you really have to look at all the other morphologic findings, and they trump whatever the Doppler findings are. So if you have flow and you have all these other morphologic findings, you're lucky that you have flow, means that it's urgent and you still need to go to the emergency room. So here's a nice example of an ovary who had all those findings. Beautiful edematous ovary with a little, tiny little hemorrhagic corpus luteum, follicles pushed to the periphery, and beautiful twisted vascular pedicle sign and free fluid. But look how much nice flow you have the ovary. It does not mean that this is not torsed. Here's another example who you can see really nicely find the twist. And notice the vascular pedicle is so edematous, because again, it becomes really engorged and doesn't necessarily, before the blood flow gets cut off. So what about CT and MR findings? Now, I know it's an ultrasound course again, and you say, well, why would I use this cross-sectional modality? But I have to say, sometimes you are reading the CT or reading the MR, and there are things that you can look for, and this is helpful to know. Also, it's important to know that if there is an abnormality present on the CT, which is done in the ED, and you don't find any other causes for the pain, perhaps it's really helpful to get an immediate ultrasound. However, if the nexa looks completely normal on the CT, which you can say really, and symmetric, no funny business, basically, you can say you don't need to get an ultrasound to confirm it. So here's a patient who actually, this is a long time ago we had, and she never even had an ultrasound because she was so morbidly obese that they could not really see anything on the ultrasound, and it's a beautiful example of enlarged ovary, follicles pushed to the periphery, free fluid, and a beautiful twisted vascular pedicle sign on the coronal MRI. And then in this case, they also gave gadolinium, but I have to warn you that if you do post-contrast, the ovary is so edematous that even though it still has flow, it might take very long time when the enhancement will show up. So that is not, it's quite tricky to diagnose that. Now, I said that a lot of times a benign mass such as dermoid can cause the ovarian torsion. And what if the dermoid replaces the entire ovary? Like, there's no way. Where is the stroma? How can I say if it's edematous? Where are all these morphologic signs? So then it gets really tricky, because dermoid shouldn't really have flow. That's when you really have to look with the twisted vascular pedicle, rely on the symptoms, and these cases, one might consider to go to cross-sectional imaging to see if you can find it. Depends also on the size of the lesion. So this is an example when there was a dermoid, and you could see that the twisted vascular pedicle kind of looks like mass-like next to the ovary. See, the other cine is not playing. Here it is. You can see the twist, and next to it was the ovary with a dermoid. So really look for those. This is very helpful in those cases. This other case, we're a little bit more lucky. You could see the edema, the peripheralized follicles, the twist, and on the next image, you could see the dermoid components. So if you have ovarian stroma, obviously you can evaluate it, and you could see this is most likely torsion, but sometimes you don't have normal stroma and the dermoid has replaced the ovary. So here's an example on a CT where the patient came in with acute left lower quadrant pain and was called to have 2 dermoids, and then not much comment on it, but thankfully the clinical team really sort of said, well, clinically we really strongly suspect torsion, and so of course we got the ultrasound and it showed edematous ovary with the follicles pushed to the periphery, and then we went back to the CT, went to the coronal image, and really if you squint your eye, you could see these follicles pushed to the periphery, and also notice that that dermoid was actually rising from the left ovary, not from the right, and that's what caused the torsion. Here's another patient, 36-year-old, with acute right lower quadrant pain, and nausea and vomiting. And on the cine, it was really hard to find the ovary-free fluid. And you say, well, it kind of looks like a twisted vascular pedicle, and there's a huge mass. Is the mass coming from the uterus or adnexa? And in this case, we figured we're dealing with the torsion. Could it be possibly a necrotic fibroid? And then we moved on to the MRI, and that beautifully shows you that there's a claw sign from edematous tube and the ovary, and this was a tourist a fibroma, which led to this process here. What about in pregnancy? Now, I told you that the ovaries are usually quite enlarged during ovarian torsion, but during the pregnancy, the ovaries are suppressed, especially in the second trimester, and so the size discrepancy is not really that big. So very subtle changes can represent ovarian torsion, like in this case. So really, with the ovarian torsion, highest predictive value is enlarged ovary with peripheralized follicles. There could be plus minus abnormal Doppler and presence of fluid in the cul-de-sac in a patient with acute pelvic pain. Recognize with twisted vascular pedicle when you see it, and do look for it. And look for subtle changes on the CT and MRI if they are ordered first. An MR can be used in pediatric patients and perhaps in larger patient population if ultrasound is inconclusive. We talked about this a little bit, should we rely on a CT? I would say yes when it's completely stone cold normal on the CT, that nexa, don't pursue the ultrasound. But if you see some findings, I think it's helpful to take the next step and do the ultrasound. And if you can't explain the symptoms with other etiologies in the pelvis, it's very important to do the ultrasound acutely. Like in this case, it was a young woman, 24-year-old, presented in the emergency room with a chronic intermittent right lower quadrant pain. It was rule-out epi versus ovarian torsion. And appendix was normal. Noted to see the left ovary. And the right ovary, we said, oh, there's perhaps a benign appearing cyst. But the patient ended up having an ultrasound, and look what we found on the ultrasound. What was called a cyst was actually extremely edematous ovary, which had all the signs what we have talked about, the twisted vascular pedicle, peripheralized follicles, edema. And the teaching point from here is actually that a very edematous ovary can mimic fluid or cyst, and so if you see that and you can't explain the symptoms with other findings, recommend an urgent ultrasound and don't wait. So here's another young patient, 11-year-old, right lower quadrant pain, was evaluated for appendicitis, and this was a second opinion for us, and we were doing the ultrasound, then we went to the outside CT. And unfortunately, there wasn't much to do now because this was several weeks later when we did the ultrasound, but there was a twisted vascular pedicle, enlarged ovary, which was thought to be a cyst, and that's why they waited for a while with ultrasound, and now we were dealing with a dead ovary. So if you see abnormality, important to really get the ultrasound right after. So now we are looking for pitfall cases or very unusual cases. So this is massive ovarian edema And basically, it's a rare entity, but it's important to keep this in the back of your mind. So if ovaries enlarge out of proportion to symptoms and there is preservations of parenchymal flow, like those patients don't really have pain. So basically, the ultrasound findings and MR imaging findings can be very similar to ovarian torsion. However, if you look very carefully, the ovary is massive. You could see the follicles in the periphery. You could see that this is really ovarian stroma, which is edematous. You could see a little bit of stromal strands. And the key is also make sure there is no hemorrhage into it on the T1 imaging. So these patients, this can occur during pregnancy, and these patients are managed expectantly. A very similar case of massive ovarian edema. This was a 32-year-old with a subacute right lower quadrant pain, had the ultrasound, very edematous ovary, but she wasn't really tender at all. And it was so strange. And I actually was kind of like, well, should I get the MRI? Should we not do the MRI? And then we got the MRI, and it was quite surprising to see what we saw. We did see the ovarian edema, but what we found was there was a subacute appendicitis. So the appendix had been inflamed and was dripping down to the ovarian pedicle and basically caused that to become edematous and twist off the lymphatics and the veins. I mean, obviously, totally unusual case, but it happens. So they went back in, did the surgery with the general surgeons and GYNs, and they actually managed the ovary expectantly because once the inflammation away, the ovary size decreased. Okay, so we're almost done. I just wanted to add one more entity here, which can be confusing, and we're not going to go into the details of PID. Just wanted to mention that 35% of the time, the initial diagnosis is incorrect. We have to remember the clinical history, that there has to be history of sexually transmitted diseases or some sort of intervention or procedure which can put the patient at risk of infection. And then who gets the imaging is really patients who have a palpable mass, severe illness, or no response to oral antibiotics. And then when we do get the imaging, there can be a wide spectrum of findings because there's a wide spectrum from endometritis to tubovarian complex to abscess. But I'm just going to get to the point in a minute. So here's the tubovarian complex is if you have an inflamed fallopian tube and you can distinguish a normal ovary from it. And then if you have a tubovarian abscess is when you can't really distinguish those two ovarian tube from each other. So on ultrasound imaging is pretty much usually clear. Now sometimes when this can be a pitfall is as it was in this case. This was a CT, came through the emergency room, 45-year-old, recently diagnosed with diabetes and intermittent right lower quadrant pain, had elevated white count. They said appendix is normal. There's a cyst in the nexa. Maybe follow up as an outpatient. But notice there's a thickening of the cyst wall. There's a lot of stranding. And, I don't know that I would really leave that. And also, what then was the cause of the right lower quadrant pain? So patient had a follow-up ultrasound. Looked kind of funky, they weren't sure what it is, and they said, well, let's send it to UCSF for a GYN consult. So the patient, it was delay on getting the appointment and so forth. So patient again came back to the emergency room, and now we're got another repeat CT, and you could see that there is really rip-roaring infection. Now it's involving the adjacent bowel and everything. So this is sort of a subtle pickup on the CT, not to miss a tubovarian abscess. Perhaps we would have not missed that on the ultrasound in the proper clinical setting. But an important thing, if you have adnexal findings, do try to interpret them and try to put them in context with the clinical picture. So the take-home points is there is imaging overlap, and the key is to correlate the clinical history and talk to your GYN colleagues. If things just don't make sense, and we always tell them, treat the patient, not the picture, and they tell us the same, well, we have to follow what makes most sense. Also, for the hemorrhagic cyst versus ovarian torsion, key is to look for the stretch surrounding ovarian parenchyma versus stromal edema with peripheralized follicles. And MRI is helpful if ultrasound is indeterminate and does not fit the clinical findings. CT, you can really do more with the CT than we are doing, I think, as I always tell the residents, please look at all the multiplanar reformats, make sure you look at all planes, and you can really look more and evaluate at Nexa more than we are used to on the CT. And if you do something, you see something which is abnormal, don't wait for sort of an outpatient follow-up. If you can explain the symptoms on the CT with other processes, do get an urgent ultrasound. And so just after all this, wanted to see what you think. This is a 25-year-old with acute right lower quadrant pain, hemorrhagic cyst versus torsion. Does it look like a torsion? Does it look like it's a hemorrhagic cyst? What do you think? Well, the world is not perfect. Again, I got a call from the OR. Hemorrhagic cyst was mistaken for a torsion. If you go back, you can see here's the stretched ovarian parenchyma, and here's the hemorrhagic cyst. And you could really see the sort of the Doppler flow as well in the periphery, and you could see a little bit of layering of the hemorrhagic material on the CT. And very last case here is a 68-year-old with left lower quadrant pain from urgent care, 5 o'clock case, and this, I think the CT is running a little bit slow, but if you could see there's a very large, complex cystic process happening in the left pelvis. Now, in this case, I would say that we immediately went to the MRI, and we could see the twisted vascular pedicle. She had a twisted benign ovarian cyst. And why did we go straight to MRIs? Just because of the based of the size of the lesion. It would have been quite difficult to evaluate in a postmenopausal woman to figure out what's normal ovary, what's going on. And so, again, it can happen in postmenopausal patients, and if the lesion is large, consider doing that an MRI to find the vascular pedicle. Thank you for your attention. Keep doing your best, and don't give up.